Hi, everybody, and welcome to this evening's webinar on smouldering MS. We're delighted that you have joined us for this session. Smouldering MS shines a light on the challenges that happen beneath the surface, changes that can shape long-term outcomes. And understanding it helps to empower people living with MS, their families, and their clinicians to act sooner to protect quality of life. We're really delighted to be joined by Professor Gavin Giovannoni to present on this topic. Gavin Giovannoni is a professor of neurology at the Blizzard Institute, Faculty of Medicine and Dentistry, Queen Mary's University of London. His clinical interests are MS and other inflammatory disorders of the central nervous system. He's particularly interested in clinical issues relating to optimizing MS disease-modifying therapies, and his current research is focused on the Epstein-Barr virus as the cause of MS, strategies to prevent MS, MS-related neurodegeneration, and MS therapies. His team is focusing on translational research and has an active clinical trial program. A quick reminder to everybody that we are recording this session, so if you miss anything, you're going to be able to watch it back again. If you'd like to submit a question throughout the presentation, you're very welcome to do so through the chat function or through the Q&A. So we'll be keeping an eye on them there, and we're going to hold all questions until the end. We've also been sent some online, so we're going to be able to mix them through, and we're going to get to as many of those questions as we can. One thing that we just do want to note is that unfortunately, the whole country is in a weather warning at the minute, so technical disruption is a real possibility. We will do our best to proceed as planned, but if there are any issues, we apologise in advance for this. We do have some contingency plans around it, so we should be fine, but just as a quick warning. And finally, we'd really like to thank our sponsor. So this is a non-promotional webinar that's been organised and funded by Sanofi, but they haven't had input into the presentation itself. So with that, I am going to hand you over to Professor Giovannoni to talk to us about the topic of smouldering MS.
Thank you. Thank you. So this will be, I'll try and make it as easy as possible because some of the slides will be a little bit complex, but I will explain them. And this term smouldering is a descriptive term. It wasn't invented by me or anybody in my group. The actual term relates to a pathological under the microscope of a particular type of lesion that was actually reported for the first time in the mid-70s by a neuropathologist working out of New York, Cedric Rain, and his collaborator described the smoldering MS lesion. And we think it's a very good descriptive term because it's referring to those burning coals that are responsible for worsening MS outcomes or disability, which you can't see necessarily with relapses. I've got to point out to you that I've got a large number of disclosures. So one of the problems we have in academic neurology is it's very difficult to do very expensive experiments like testing new therapies for people with MS. So that's why we have to do them in partnership with the pharmaceutical company. And I've been involved in the development of many MS therapies, including a new one that's emerging. And I sit on the steering committee, and that's one of my conflicts in relation to this particular presentation that Sanofi is developing the compound. So I'll start off with a case study to illustrate the point I'm making, because a large number of you will recognize what I describe in this patient. This is a typical patient I would see in my clinic. About half my clinic is this type of patient. A 48-year-old woman who's had MS for over a decade, 12 years, and she was on interferon beta for 9 years. And her last relapse was a long time ago, 8 years ago. And she has lower limb weakness and some bladder problems. And her annual MRI scans, which are done as part of the monitoring protocol, have shown no new lesions, but there is some gradual shrinking of her brain, which is noted in MS patients. It happens in normal people, but it's a slightly accelerated rate in people with MS. And she's complaining that her walking distance is gradually deteriorating, particularly over the last 3 years, and she can now only manage about 200 meters. Because of a bladder problem, she's been getting recurrent UTIs, and she also has problems with constipation. And her EDSS is 5.5. So this is at a stage where she's not using a walking stick, but she's almost having to use one. But she's at that level of about to become needing a walking aid. So the question we always ask ourselves in clinic, does this patient have what we would call secondary progressive MS? In other words, worsening in the absence of relapses. is a secondary progressive disease active? Because if it's active, we have the opportunity of giving a treatment for that condition. There's a licensed drug called saponamide that we can use. As a neurologist, we'd have to ask the question, would this patient be eligible for a switch? And if yes, what kind of considerations would we need to take? Now, the problem with labeling this patient with diagnosis of secondary progressive disease is that it has quite severe negative connotations, as you're probably aware. First of all, I don't like the term progression because if you look at the definition of progression, it's actually an advance, an improvement generally. And so we've got this term stuck in the MS lexicon calling worsening disease progression. And I think we should get rid of the term progression and secondary progressive disease. And we should probably better talk about declining worsening function, which is kind of what the descriptor should be, in my opinion. And obviously, as you know, embedded in our clinical, the way we describe patients, we have this term progressive disease, and we talk about active secondary progressive disease, people who continue to have relapses or new lesions on their scan. So that's what we call active secondary progressive disease, or non-active, there's no relapses and no MRI activity. And then obviously there's the primary progressive type, where the course is worsening from the outset. Now, the problem I have with the terminology is that when you say to somebody they've got secondary progressive disease, it's giving them a new diagnosis. It's like giving them a second disease. It's a double disease. And there's always been these very negative connotations about the label of progressive disease in the past, because most people think, oh, there are no treatments for secondary progressive disease. It's a one-way street. I'm going to end up in a wheelchair and disabled. And I think that's the problem we face, is that we have this stigma attached to the label of secondary progressive disease. And it turns MS into two diseases rather, well, more than two diseases rather than one disease, which MS says it's one disease. And this is entrenched. So our current classification system actually defines MS based on what we see clinically as a neurologist or a healthcare professional into two types. The so-called relapsing type, and there could be just one attack when it's called clinically isolated syndrome, or relapse and remitting MS. And on top of that, we have a descriptor called active or inactive. Now that refers to when the relapse or MRI new lesions on MRI occurred. If they occurred in the last 2 years, it's active. If they occurred before, more than 2 years ago, that's inactive relapsing remitting MS. And then on the other side is when people have got gradual worsening for at least 6 months. Some neurologists prefer 12 months, but the definition is 6 months worsening without superimposed relapses. That's called progressive disease. And there's two types, there's primary and secondary progressive. And then we talk about people having worsening or not worsening. And the reason why I say this is because worsening, people may have the label of progressive disease, but they may be stable. In other words, they haven't noticed a deterioration in their functioning. And so this is another descriptor that's really important, because when it comes to some of the new treatments, we're going to only be able to use them, I think, in people that have a label of worsening disease. And I'll try and explain that to you. Now, why this classification system came out, and I think it's wrong. So I'll be honest with you, I don't think we should be using this classification system anymore. But that causes problems. So it's a one-way street. So when you've got this, if you're on the left-hand side, relapsing, remitting, and then you move to the right-hand side and you call progressive, like you can't go backwards. The classification system doesn't allow you to go from having a progressive label to having a relapsing label, relapsing, remitting MS. So it's a one-way street. And the problem is it causes what I call a cul-de-sac, a dead end, because once you get given that label as having secondary progressive MS or primary progressive MS, you're limited to one therapy that's licensed. Well, at least in the NHS where I work, if you have SPMS, you have to have active SPMS, and then you're only eligible for a drug called saponamide. And if you've got primary progressive disease, you can only have ocrelizumab. And again, you have to have active primary progressive disease. So your MRI scans have to show new lesions or enlarging lesions. If your MRIs are stable, then you would not be eligible for saponamide or ocrelizumab. Now, I want to go back and explain to you why we as an MS community have sliced up MS into these actually 4 different types. And it's based on how drugs get licensed. So in the United States, if you have an orphan disease, and an orphan disease is a disease that's quite rare, there has to be less than 300,000 people with the disease. It used to be 200,000, and I see it's increased to 300,000. And then you can actually get a drug license on one trial. You don't have to do two studies. And then you get also other incentives for doing the studies. So when the drug companies were developing interferon beta for MS, they went to the FDA and in the United States said to them that we would like to develop interferon as a treatment for MS, but we want to use the orphan drug pathway. And the only way they could agree to use the orphan drug pathway was to classify MS into three diseases: relapsing remitting, secondary progressive, and primary progressive. And because each component was less than 300,000 people, or 200,000 back then. And that allowed drugs, and that stuck. So now when people develop drugs in all over the world, you have to do trials in all three subtypes. You have to do a trial in relapsing MS, in secondary progressive MS, and primary progressive MS, and it gets incredibly expensive because you now have to do two trials now because MS is not considered an orphan disease anymore. So you have to do two trials in the relapsing population. You can get away with one trial in secondary progressive and one trial in primary progressive. So four big trials rather than two, it doubles the price, and actually more than doubles the price of drug development. And I say this because when you go back and analyze the different stages of the disease, there's no difference in terms of the underlying biology. It's MS. So I think we should go back to calling MS MS. And then on top of that, we have descriptives that give us clues on how to treat the disease. And I'll explain that at the end of the talk. Now, smoldering MS was only really identified when we got very effective therapies. So in the days of interferon beta and glatiramer acetate or Copaxone, we didn't really control the disease activity very well. So most people continued to have attacks, relapses. But when we got a drug called nelulizumab or Tysabri, and most people became free of relapses, so they became relapse-free, we then noticed that a large number of them were still getting worse, despite not having any relapses and despite their MRIs being stable. And that was called, we called that progression independent of relapse activity, because these people were rendered relapse free, but they were getting, in other words, we exposed the underlying progression of the disease in a relapsing population. So what we were saying then is that by getting rid of the relapses, we were exposing worsening that was occurring without having any new lesions on your MRI scan. Now, the term progression independent of relapse activity is a mouthful, and it also refers to a specific situation that occurs in clinical trials. We monitor worsening by doing a disability score, monitoring time, 25-foot walks, and that kind of thing. And it's done every 3 months, which doesn't really reflect what happens in clinical practice. So that's why we evolved the term smoldering, to try and capture what happens in clinical trials, but also what happens outside clinical trials. And I wanted to show you that it doesn't only happen with Tysabri that you get progression independent of relapse activity. As you know, ocrelizumab, the other name for it is Ocrevus, was licensed for both relapsing and primary progressive disease. And it was compared to interferon beta. And you can see that even in interferon beta patients, okay, the majority of worsening, almost 80%, was due to smoldering disease. And in the ocrelizumab treated patients, it's almost 90% of the worsening events were due to smoldering disease, PIRA. So when we have very effective therapies, we expose this worsening both in relapsing and even more advanced MS. And so this is why this classification system is wrong, because it also should have worsening occurring at both stages of the disease, not just in the progressive phase of the disease. Therefore, this dividing line is artificial, and the pathology, what drives smoldering MS, is almost certainly present from the very beginning of the disease. We just haven't looked for it properly. And the reason why we don't see it is because very early on in the disease, people have the ability to compensate for the damage that's occurring in the brain and spinal cord. So you are compensating for the damage by using the reserve or the resilience of the nervous system. And then when that runs out, that's when you start noticing worsening. So it's basically a detection problem. If we use better methods to detect the worsening early on, we will find it. Then we need to find it as early as possible to protect the brain and spinal cord. And we know this occurs. So this is actually a study that was done across Europe, looking at the MRI scans, and they're looking at how much brain volume is how much atrophy or brain shrinkage is occurring. And it doesn't matter if you are CIS, clinically isolated syndrome, having just had one attack, relapsing, secondary, or primary progressive MS. When you actually look at the relative loss of brain volume, it's occurring across all stages of that disease. And even when you and even and even when you look at patients that got asymptomatic disease, so these are people who are picked up incidentally on MRI. They may have an MRI for a headache, for example, and they have lesions that look like MS, and you track those people, they're also losing brain volume at a similar rate to other stages of the disease. So this is why, and I think the brain volume shrinkage that occurs, the shrinkage of the brain that occurs in MS is actually integrating the damage that's occurring. This happens in other organs, by the way. So when you've got chronic kidney disease, the shrinkage of the kidney is very, very closely related to the loss of function. And we think the same thing happens in MS. The shrinkage of the brain and spinal cord is linked to loss of function. And that is happening from the very beginning of the disease. And this is an example. So this is actually a study done in Italy. So these people were picked up having scans for other reasons, not because they were thought to have MS, usually for headache, or they were part of the military wanting to be pilots and they have to have MRI scans before they become a pilot. And they got a group of these people that have asymptomatic MS. They then used this very sensitive glove where you did fine motor movements, and they picked up in the very early stage that people had abnormal movements of their hands, and these abnormal movements would get worse over time. So they're using what I would call a very sensitive test. So if I saw somebody with a radiologically isolated syndrome and asked them to do a finger tapping test, I wouldn't pick up any problems. I'd say it looked normal. But when you use a more sensitive screening test like this glove, you pick it up compared to normal people. So this is actually saying that if you look closely enough with more sensitive tests, you'll pick this up. And we should know about this because I'm not sure how many of you ever had a problem with your heart, shortness of breath or chest pain, and you've gone to see a heart doctor, a cardiologist. They would never pass you off as having a normal heart without stressing that heart. And I trained as a medical registrar before I did neurology, and I used to spend a lot of time putting people on treadmills and exercising them to their maximum so we could actually monitor the electrocardiogram, the ECG, to see if we could find abnormalities. And that's what we would call a cardiac stress test. You have to stress the heart to make sure it's normal. And they're much more complicated stress tests now than putting people on treadmills. You can do it with MRI scans and everything like that, but you don't send somebody away with a green tick saying you're fine without doing a stress test. And we've done the same in MS. So this is actually a study where this is from Edinburgh, where Don Mahad's group has taken people that have got very low EDSS scores. So these are EDSS scores of 0, 1, or 2. And you wouldn't note that these patients had any problems. And then when you put them on a treadmill and exercise them, you brought out problems with their walking. You exercise them and you brought out what we call exercise-related abnormalities. And so that's a form of stress test as well. So I actually think we should be doing neurological stress tests to detect worsening that's occurring before people with MS complain about it. Because we can have treatments now to monitor to treat that process. So that's why I personally think the real MS, what MS is the gradual worsening that's occurring from the beginning of the disease. And when you talk about superimposed relapses, attacks, and the new lesions that come and go on MRI scan, that's actually the immune system's response to what's causing the disease. And so this is what we call smoldering MS. And the smoldering-associated worsening is the worsening we detect by looking for it, using MRI scans, exercise tests, hand function tests, cognition tests, very sensitive visual tests, hearing tests, balance tests, things that are done outside the neurological examination. Because our neurological examination, which we use for the EDSS, is just not good enough. Okay, and so we'll find that a lot of worsening, okay, is occurring outside of those measures that we use for defining PIRA. Yes, so some people with smoldering MS will have PIRA as defined using the measures we use, but some people will have a stable EDSS score, for example, but we will detect changes on their cognitive tests, changes on their visual acuity, changes on their hearing and balance that's not detected on the EDSS. So this is why I think we will go in future into a phase where we're looking for the subtle worsening that's occurring that we're not picking up with the EDSS score. Now, when we now know that there are processes that is driving smoldering MS, and I just want to this particular cartoon, the slide kind of illustrates some of the things that we should be targeting. So we know that people with MS have demyelination. That's the insulation of the nerves is stripped off, and those fibers that are demyelinated are primed to die off over time. So we should probably be developing remyelination therapies to protect those nerves from dying. We know that in the brains of people with MS, there's this type of inflammation that's not driven by lymphocytes, white blood cells from the periphery. The actual cells within the brain, they call them microglia, are activated and they produce a lot of toxic chemicals that damage the nerves. And that's what we would call innate immune activation. And the theory is called the hot microglia. So this is a type of inflammatory cell in the brain that's driving it. We do know that in MS there are actual B cells. These are the cells that make antibodies, and plasma cells that also make antibodies that are probably also driving worsening of the disease that we can't get to with our therapies because our therapies don't go into the brain very well. Iron is toxic, and people with MS have free iron as a result of inflammation. Energy deficits, the inflammation damages the little energy powerhouses called mitochondria, and people with MS actually have a functional energy deficit within their brain. And that's why some people want to treat MS with oxygen therapy and things to boost mitochondrial function. And then there's this theory that MS is caused by a virus, and there may be viruses in the brain, and that's why some of us are wanting to test antiviral things. So there are a large number of targets to treat smoldering MS, okay, that are goes beyond our current therapies that are typically working in the periphery, in the peripheral in the immune system rather than within the brain. And so just to say to you, one of our drugs called cladribine, actually we think targets at least the B cells. It goes into the central nervous system and kills central nervous system B cells. So this is one of our therapies that's already available that we think targets one component of smoldering disease. And then there's this new class of drugs called the BTK inhibitors, Bruton tyrosine kinase inhibitors. And these also are small molecules. They go into the brain and they also inhibit B cells, but they also go into the brain and they all switch off the hot microglia. So they're working as dual therapies. And one of these drugs is going to be coming out, we hope, in the next 6 to 12 months as a treatment for smoldering MS. And it's been shown to work both in a relapsing population and in a second progressive population. So that's exciting. And the results of the primary progressive trial will be available quite soon as well. So hopefully it should work in primary progressive. This is going to be a drug, I think, that's going to work across the whole spectrum of MS, targeting smoldering pathology. Now, what I want to say to you is that if you have MS, our treatment target in terms of what we expect from our therapies is going to evolve, and it has evolved. So in the past, we were just happy with reducing relapse number. So the interferon beta and Copaxone essentially reduced the attack rate by about a third and severe attacks by about a half. We weren't satisfied with that, and then we wanted to render people free of attacks completely. We call that no evident inflammatory disease activity. So you have to be MRI clear, no new lesions in your scan, no relapses. And now we're moving into the future where we want to actually stop smoldering MS. So we want to stop this accelerated shrinkage of the brain. We've got these lesions that get gradually larger. They call slowly expanding lesions. We know that those are not good for your brain. They correlate with worsening and they worsening disability, and they also correlate with cognitive problems. And we want to stop those getting bigger. And we want to also stop lesions occurring in the surface of the brain, and we want to normalize neurofilament levels. Neurofilaments are released when you damage the nerve fibers. And so that's a marker of nerve fiber damage. We want to make sure that those neurofilament levels remain very low. And then I personally think we have to actually kill the B cells and the plasma cells in the brain because I think the antibodies they're producing are damaging the brain. And so that's why I think we're going to have to scrub the brain clean in the future of the so-called oligoclonal immunoglobulin bands that occur in MS. So our therapeutic target is evolving. Okay. And so you having MS now is going to be part of this generation where we're going to want you to be free of inflammation plus free of smoldering disease. And then obviously we want to treat you beyond MS. So this is where we want to give you therapies that could potentially improve your function. That's at the moment science fiction. We don't have any therapies there, and they're very difficult to develop those treatments. And then we also want to promote brain health. So this is actually doing things that help with aging mechanisms, for example. So in the general population, not smoking, exercising, good sleep, not drinking too much alcohol, preventing getting hypertension, diabetes, stopping yourself getting vascular disease. These are all things that the general population are expected to do. Well, we know that people with multiple sclerosis should do them as well because they have been shown to hasten the worsening that occurs. So this is why it's not just about targeting MS mechanisms. We also have to target brain health as a treatment target in MS. So going back to this lady who's got, in the past, we would say she had MS, had secondary progressive MS. I personally now, if I saw this lady, I would never put in the notes that she's got secondary progressive MS. I would document that she's getting worse, but I would leave the label away simply because I want to have other options for this patient. Okay. I would almost certainly want to not only rely on the brain scan, I'd also want to see what's happening in the spinal cord, because sometimes you can get spinal cord lesions that occur independently of activity in the brain. So I'd almost certainly want to have a spinal cord image. And I'd probably offer this lady a lumbar puncture to measure the neurofilament levels in a spinal fluid. In the future, we'll be able to do the neurofilament levels in the peripheral blood. So it's a blood test. But at the moment, that assay is not available and it hasn't been validated. So we still rely on spinal fluid neurofilament levels. If the neurofilament levels are raised, then we have potentially the option of offering this particular lady a switch to another drug. But the switch to the other drug should be to a therapy that goes into the central nervous system to target these mechanisms that are driving smoldering MS. Okay, and then obviously depending on what therapy we choose, okay, we'd have to de-risk it by doing blood tests and making sure she doesn't have any infections and all that kind of stuff. So the de-risking is dependent on which therapy we're going to switch this patient to. But clearly she needs something else apart from interferon beta. She needs a new therapy to target smoldering disease. So just to say to you that our classification system of MS is changing. It hasn't completely changed. From a patient perspective, somebody with the disease, I mean, you really want to know if you really have two phases to the disease. You're either pre-symptomatic or you're symptomatic. And then you go through what we call the pre-diagnostic and the diagnostic phase. Okay. And then you get given the label of MS. Now, in the past, we used to say to people, you had asymptomatic prodromal, or you had clinical isolated syndrome or MS. So we had all these classification systems. I think in the future, we're going to say you either don't have MS, you may be at risk of MS based on your family history or something, or you have MS. There's none of this salami slicing up. And then we're going to say to you, now that you've got MS, do you have evidence of focal inflammation? Do you have relapses or new lesions on your scan? Or are those lesions enhancing after we give the gadolinium contrast agent? And if yes, then you need to be on a therapy that's anti-inflammatory. So these are all the therapies we know about. Okay, so it could be one of the S1P modulators like fingolimod, interferon, tyramacetate, natalizumab, ocrelizumab, ofatumumab, cladribine, alemtuzumab. All those therapies have been shown to be very good anti-inflammatory therapies. And then we're going to ask the question, once you've been rendered free of that, do you have evidence of smoldering disease? In other words, are you getting worse despite us having controlled the inflammation? And if you are, then we want to probably add in a new drug, okay, on top of the existing drug, or switch you to a drug that has dual activity, targets both processes. That's where we're going to be going. So the treatment target going forward is going to have what I would call two axes, okay? So on the top axis, it's anti-inflammatory, and our target is to render you free of evident inflammatory disease activity. And we measure that clinically with relapses or on MRI using new lesions, for example. And then on the second axis, we want to render you free of smoldering disease activity. Okay, and that's where smoldering disease activity is called SAWS, smoldering-associated worsening, and relapse worsening is called relapse-associated worsening. So we want to have you stable on both of these axes, and we'll call that stable MS. And hopefully we can do that with one drug, but we may need two drugs. We may need three drugs. That's where we're going to go in the future. We're probably going to be moving, like we do in cancer therapy, to combinations. Okay, I envisage that our future treatment of MS is not going to be with one therapy because there are different processes that need to be targeted as a treatment. So I'll conclude then. My main message to you is MS is one disease. This 2, 3, or 4 disease classification system is wrong. It's not based on biology. It's based on a discussion between regulators and pharmaceutical industry to get drugs developed. MS is not what we see necessarily in the clinic on MRI. It's a biological disease, and I think we have to appreciate that this is biology we're trying to treat. The current classification system of dividing MS up into all these subtypes is just not fit for purpose. Okay, so we're going to have to change that. And I don't like this term active, inactive, because MS is rarely inactive. When you actually look in the brains of people who die in old age from with progressive disease, they often have inflammation ongoing. So they've been classified as being inactive, but when you look in their brains, they've got activity, inflammation. I personally prefer the term smoldering. I think PIRA is a progression-independent relapse activity. The term PIRA is not going to go away. I think that's going to be used in clinical trials. And I think the regulators like the MHRA in the UK or the European Medicine Agency in Europe or the FDA in America are going to probably accept the definition of PIRA as an outcome measure in trials. So we're going to try and treat people to reduce their PIRA rates because we measure that in trials. But I think we have to go beyond PIRA because a lot of the stuff is not measured using our clinical outcomes in clinical trials. And I've hopefully given you some insight that there are lots of targets in the brain and the spinal cord that are worthy targeting with our therapies. Can we remyelinate demyelinated axons? Can we switch off those hot microglia and tackle the so-called innate inflammation in the brain? Can we scrub the brain clean of these B cells and plasma cells that are producing antibodies that are damaging the brain and spinal cord? Can we restore energy metabolism in the brain? Can we target early aging mechanisms? That's one of the issues that you may not be aware of. What protects us from age-related degeneration of our brain and spinal cord is the size and the reserve of the brain. Almost everybody who lives long enough will develop degeneration of their brain and spinal cord. We see that with hearing, with vision, with balance. That's just life. Your brain and spinal cord were never designed by evolution to last until you're 90 or 100. So there's this gradual deterioration that occurs from about age 35. Now, because MS reduces the resilience of the reserve, those aging mechanisms come forward. They come forward. And they come forward by quite a lot, actually. And possibly decades, because of the damage that MS causes. This is why we've got to treat MS early to protect the brain and give it, get people with MS to old age with much resilience left, so they don't have to age early. So I put early aging here because there are treatments being developed for aging mechanisms, and they may be appropriate for MS patients in the future. And then obviously we mustn't exclude novel ideas, that the fact that MS could be due to viral infection. And I personally think that the real MS is smoldering disease. I do not think it's relapses, and I don't think it's focal MRI activity. I actually think what we see in terms of relapses and new lesions is that our immune system's response to what's causing the disease. So there's something happening in the brain and spinal cord, and the immune system finds it and causes a relapse. And if you take the immune system away, that process rumbles on, causing smoldering disease. And obviously, these concepts have enormous implications for future drug development, for example, and how we talk about MS. Okay, and then we as healthcare professionals and you as people with the disease mustn't shy away from being labeled as having smoldering disease. It's just a label for a process that's occurring. So we won't have to say you've got progressive MS. We'll keep that term away. We'll say you've got MS. You've got no evident inflammatory activity, but you're getting worse. Therefore, let's treat it. Now, this was a problem in the past. Some of you will, because I run a social media site called MS Healthy, it's amazing how many people with MS talk about being gaslit, ignored by the healthcare professionals when they go to them and saying, I know you, because the neurologists say you're stable. Your MRIs haven't changed. But the people with the disease say, I am changing, I'm getting worse, and they get ignored. They just get pushed out the clinic and say there's nothing to be done. And I think that's going to have to change. There's going to have to be a realignment, because at the end of the day, the treatment principle that drives most diseases is early diagnosis and early treatment to protect the end organ, to protect the brain and spinal cord. And this will not only apply to inflammation, relapses, but also apply to smoldering process. We want to diagnose this as soon as possible, because then you've got the most chance of altering the natural history of the disease. Well, I'll stop there and take questions. Thank you very much.
Great. Thank you so much, Professor Giovannoni. Really, really valuable information in there, and so much of it. And I think that idea of the cognitive stress test is a really interesting concept. It's also really interesting to hear about the potential of treatments that will help to tackle smoldering MS. And I suppose also that classification system and your comments on that, I think it will be really interesting to see what developments might happen in that space. Additionally, I just think what you had to say there around healthcare providers needing to really hear the changes that people are reporting to them, even in the absence of maybe radiological evidence and so on. I think it's really great to hear that conversation. I'm sure it comes as no surprise to anybody that we have lots of questions in, so we might just try to get right into them, so we can get through as many as possible. And I see more coming in on the Q&A, but we have been sent some in advance, so it will be a mix if that's okay. So the first question is, in relation to treatments generally, is there a consensus on an upper age limit? And I see in the Q&A somebody's asked a similar-ish question. Well, they've made a comment about being told that they can't have treatment as they're over 60. So are you aware of a consensus on a kind of an upper age limit?
Yeah, so the problem we had with age is because in clinical trials we used to define an age limit simply because we wanted to exclude what we call comorbidities that occur with aging. However, I might as well say I lobbied against this, and we actually did a trial called the OHAN study, where we actually tested ocrelizumab in people with wheelchair users, and the trial was positive. So even wheelchair users, we showed that the treatments work. And then we extended the age up to 65. So, but by the way, healthcare systems, particularly in Europe and the UK, will never put an age restriction on medications because it will be considered ageist. So I think it's very difficult not to prescribe therapies based on age. So, and I push back against that. The other side of the coin, though, is the therapies get less effective with as you get older, and that's probably because what's causing the worsening as you get older is not MS, but aging mechanisms, and the treatments don't work against aging mechanisms. So the process that drives worsening disability in older people is probably compounded by age-related mechanisms. And I wish we had treatments for those things, but we don't. So you've got to expect that the response to the therapies drops off with age, and we've shown that across almost every therapy we've got. Okay, and then what happens with aging, because aging also affects immune function, for example, you get this thing called immune senescence. So this is the immune system aging. And so older people are much more likely to get infections and infectious complications as a result of the therapies. And so the risk benefit of the treatments change with age. And so that's kind of sometimes miscommunicated to people with the disease. Is not because we don't want to treat your MS, but we realize that when you're 75 and getting worse, putting you on a very powerful anti-inflammatory therapy puts you at much, much higher risk of serious complications than the benefits of the treatment on and offer you. Yeah. And so there's also that risk-benefit equation that's occurring. But it's up to the healthcare professional to explain to an older person, I'm not going to be I don't want you to go on this drug because we're going to cause more problems and the drug's going to offer you benefits. But there are safer therapies that can be offered in that group. So there are much safer therapies that you can offer older patients that will still work against MS and have a different risk-benefit profile. So it's not a case of not treating MS, but it's just of treating it slightly differently in an older population.
Great, thank you. And if somebody is concerned about gradual disimprovement, do you have any tips on how they can best raise that with their neurologist? And I think another question came in and it was a little bit similar about what kind of things should they be documenting and kind of presenting to their neurologist if they have concern?
Well, I always ask, and we ask people to self-monitor. So, we let people monitor their own hand function using an Arnold peg test that they can use at home. We get them to do time walks. I think it's something you should do that's objective. So, step counts, walking distance before you have to stop and rest, how long it takes you to do a standard distance. So maybe a walk down to the shop and back You can time it, do that once or twice a month and record it. So you've got objective measurements, and you can take it and say, look, say to your neurologist, I'm actually getting worse. This is what's happening. There are online cognitive tests. Sometimes, though, they improve because people do them repeatedly and they learn how to do it. There's a learning effect. So sometimes cognition is actually very difficult to show worsening on because the learning effects. People get better when they do task. And the same thing happens with the neural peg test. We've got some patients that have actually improved their neural peg test times because they do them so frequently, and it's because they're basically using it as a rehab tool, which is absolutely great because if the scores improve, it doesn't mean that your MS is improving. It means that you are rehabilitating yourself.
Mm.
Anyway, so self-monitoring, and we also trying to develop a questionnaire called the SAW Index, Smouldering-Associated Worsening Index, where people can fill in a questionnaire that will go across multiple domains. So this is not just targeting walking, for example. This is looking at multiple domains: uh, cognition, vision, hearing, balance, fine motor tasks, lower limb function, bladder, bowel, sexual function. So, in other words, you're tracking the impact of MS across the whole nervous system rather than just one domain. Because unfortunately, our outcome measures in clinical trials seem to be dominated by the so-called motor system, mobility,
Mm.
particularly mobility, walking. And that's one of the problems we've had. And that's why wheelchair users have essentially been excluded from trials in the past because they not walking anymore, and all our outcome measures are dominated by walking scales. So
Mm.
this is going to actually cause a real change in the way we do trials. We're going to now start thinking about targeting processes that are not normally measured in clinical practice, and people with the disease will have to monitor those themselves. I mean, the reason why I say self-monitoring is going to become the norm is because we don't have the time in clinical practice to do all those tests. It
Yeah.
take a long time. So when you go and see your neurologist, you probably get, as a follow-up, 15 minutes in the NHS, and even then, people don't often get full 15 minutes. So you can't actually do all the monitoring you want to do. So this is why it needs to be done outside of the clinical interaction. And this is where wearable devices like step counters and that type of thing are also helpful as well. So I would encourage people to develop a little portfolio of things that are important to them
Mm.
and try and get an objective measure and then record them over time. And we're talking about over months and years here because the type of worsening that occurs with smoldering disease doesn't happen in days or weeks. It happens in months and years. So this will have to be a long-term project for people with the disease.
So it's snapshots over time as opposed to like a daily monitoring. Um, okay, that's really interesting. Then another question's come in around, is it possible to have smoldering MS? Sorry, I might have mixed this up. So it's around how likely is it for someone with relapsing remitting MS to further develop to a progressive type of MS?
Well, I think it's there. I mean, most people in inverted commas with relapsing remitting MS have smoldering MS if you look for it. That's the point I'm trying to make. If you look for it, you'll find it.
Mm.
And the reason is that we find it, then we need to then give another therapy because the current therapy is not doing both. Now, the flip side of that question, I think if I need to say this, is because not everybody has smoldering MS, and and we know that because there are some people that appear to just be stable; they never get any worse. So there's a small number of people; it's about 5% have MS, but they get to old age with no disability. Uh, there's some people who never get diagnosed with MS. When they die, and when you look at their brains at post-mortem, they've had the disease, but they've never had any clinical attacks that brought it to that. They've obviously cured themselves of what's causing the disease. And we also have some people that are even quite advanced. They may be, needing a walking stick, and then they never change. They just stay on a walking stick the rest of their life. And something must happen within them that they just basically clear the disease. So I try to talk about those people as curing themselves of the disease. And similarly, we use some of our most effective therapies, and there's a small number, and I'm saying it's a minority, going to long-term remission and remain completely stable with no evidence for smoldering disease. So their brain volume loss is the same. They don't develop any worsening. Actually, they may improve. So these are people that have had the most effective therapies like Lemtrada, alemtuzumab, or they've had hematopoietic stem cell transplant, a proportion of those people just go into remission and they stay in remission.
Mhm.
And so, so there is a proportion of patients that don't get smoldering disease.
Okay.
But I think we have to, I don't think people should say, I'm going to be, unless you look for that and monitor it, you're not going to find it. So this is why I'm saying we're going to move into a phase where we're going to start interrogating people much more in much more detail to pick up smoldering disease early. Because if you have got smoldering disease, we don't want to ignore it because in the near future, we're going to want to treat it. That's why. Yeah, and if you ignore it and then wait for people to become disabled, we don't have therapies to reverse the damage. We have therapies to slow down or prevent the damage. We don't have therapies to reverse the damage, which is why we want to pick it up early so we can treat it early rather than wait until the damage is irreversible, to be honest.
Yeah. Well, that makes perfect sense, and I suppose, it's all about timing there for people as well, and ensuring that they are heard. So I think it's really important for people to kind of have, as you'd mentioned earlier, that kind of evidence in terms of the kind of snapshots over time and things like that that they can help detect and kind of point these things out. So yeah, that's brilliant. Actually, somebody did send in a question that was related to HSCT, which you've mentioned there as well. And they're wondering if it's possible to have smoldering MS post HSCT. So this person mentions that they've undergone this and they've reported slow worsening of bladder dysfunction and despite radiological stability.
Yeah, so this is well, I think just relying on bladder dysfunction, I'm just want to say is not good enough because sometimes when you've had, for example, a spinal cord lesion, it takes time for the bladder dysfunction to emerge. So that could be just a lag. So they need to be monitored much more clearly. But I just want to be frank with you. HSCT doesn't always stop smoldering disease. There is, as I've mentioned to you, a minority of people that I think go into long-term remission and we can't find smoldering MS. But I personally think that when you look carefully, unfortunately, people with a post-HSCT, a proportion of them will get worse without any evidence of new activity on their scans. They've got smoldering disease. So in other words, HSCT hasn't gone into the brain to tackle those processes that occur. Okay. And if you actually look at I mean, there was a beautiful paper that was written by Paolo Marraro, just showing you that when you actually look at over many, many years, it's probably in the region of 40 to 50% at 5 years, and we'll have evidence of worsening disability. So in other words, the I don't want to stress it, but the people who think that HSCT cures them have been so vocal, and I think people need to be aware that not necessarily going to happen. Okay, particularly people who've had MS for quite a long time, they're much more likely to have superimposed smoldering disease, even though they've been rendered free of relapses and MRI activity.
And thank you. And in relation to progression, I suppose disability is discussed a lot in relation to it. But one question here has come in around numbness in their hands and progression. I'm wondering if things like that, the kind of sensory aspect of things, are considered progression also, or is it mostly focused on disability?
Yeah, so I think you're referring to disability being motor, walking,
Sorry,
mobility.
apologies. Yes, of course.
Yeah, absolutely. So this is one of the reasons why sensory is so important. Actually, in our hand trial, which is our primary outcome was a 9-hole peg test and the EDSS, and the 9-hole peg test was much, much better in showing a treatment effect. It was almost twice as effective as the EDSS score. And the reason why, because it integrates so much information. So when you do the 9-hole peg test, which is a fine motor task, it's looking at vision. So you've got depth perception, and you've got to look. It's involving fine motor feelings, such as sensory, plus coordination, plus motor skills. So the 9-hole peg test is an outcome measure that integrates neurological function across several domains. Okay, vision, sensory, coordination, and motor. So there's like 4 or 5 systems. And whereas the time 25-foot walk is not nearly as it didn't show a treatment effect. So yes, absolutely. This is why I'm saying to you, we need to use better tests than the EDSS score and the walking time. We need to have across multiple domains because it depends where the lesions are. So, if you've got a slowly expanding lesion, which is it's called a cell, if you've got a slowly expanding lesion that happens to be in a sensory pathway, then the worsening is going to occur in the sensory pathway, not in the motor pathway. So it depends where the lesions are. I must point out, though, that the brain, the way it's designed, is a sensory brain in a sense. It's much more sensitive to perception, but there's much more resilience when it comes to sensory function than the motor pathway. Motor pathway is much more likely to present with worsening clinically than the sensory pathway. But if you look with the sensory pathway, you will find it. Okay, and the cognition is another one. I don't want to stress this, but if you look at across Europe, and this study needs to be repeated. But in 2015, we did a pan-European study that was done by a health economist, and about 50% of people in Europe were unemployed who had MS, which was incredibly high. And most of those people became unemployed when they had an EDSS of 3.5. That's before they become physically disabled. Okay. And I suspect what was driving the early unemployment is cognition problems and fatigue and hidden symptoms. In the knowledge economy, what keeps you working is your cognition, not your walking anymore. I mean, there are some professions and some work that require you to walk, but most of our current jobs are knowledge based. And that just shows you the impact of MS on knowledge-based work is very high early on in the disease. And I think this is why we should be doing cognitive tests as well. And I bet you the majority of people listening to this webinar will not be having routine cognitive tests. It'll be the minority because most MS centers do not do routine cognitive testing. They do routine EDSS scores and walking times, but they don't do routine cognitive testing. Yeah.
Thank you. Somebody has also said, seeing as it is yourself, Professor Giovannoni, who's on this, and they would like to ask how close you think we are to finding an EBV vaccine.
Well, I think the EBV vaccines have been developed. So there are two things about the vaccines. So I think the main indication for the vaccine is going to be to vaccinate people when they're young, to stop them getting EBV or to reduce the chances of getting infectious mono, to hopefully reduce the incidence of MS. That's a preventive strategy. Whether a vaccine given to somebody with MS will work is an unknown, but there is some evidence that people with multiple sclerosis can't control the virus. So the EBV is very active in their body, and that may be driving the disease. And then a vaccine may boost the immune system to control the virus. So that's another strategy. It's what we call a therapeutic vaccine, and there's a trial starting for that. So just to say to you, the vaccines they're developed. So there are companies that have got EBV vaccines that are going into trial. And I don't think, knowing about the virus, that there's any problem with developing a vaccine. I think we got so the technology is there for the vaccine. Simple as that. And we know which proteins to target, how to put the adjuvants in, and all that kind of stuff. So I think there's no what's problematic, though, is getting that vaccine taken up by governments and public health officials. Okay, getting because the government and very few people pay for vaccines privately. Okay, so in a socialized healthcare system like in Ireland, like in the UK, governments have to pay for the vaccine. So we as a community have to convince the governments that a vaccine is good, and then the individuals have to accept that the vaccine is worthwhile because there's such vaccine hesitancy now, and I'm sure Ireland is no exception. People don't want their children to have vaccines because they think the vaccines are going to cause autism and all these things that haven't been shown. So we have to counteract the vaccine hesitancy, and that's an education thing. So I think the biggest hurdle for EBV vaccines is not the vaccine. It's the payers, getting the governments to pay for it, and it's getting people to agree to have their children vaccinated, the vaccine hesitancy. So I think those are the two bigger hurdles than the actual. And then obviously, if those things are actually play into the investment, because for a vaccine company to develop a vaccine, it's not cheap. The average vaccine costs about $3.5 billion. Now, people ask why. Well, that's how much it costs to develop a vaccine. And the reason for that is there's so much regulatory stuff. The trials have to be so big. There's so much work that has to be done that it costs so much money. So the government, so these companies then have to say, we're going to invest $3.5 billion. We want some assurance from the governments that they're going to they're going to adopt the vaccine at a population level. So there's lots of health economic hurdles as well that people we don't understand that very much. But it's always an issue with vaccines is getting the governments to buy and pay for the development of these vaccines because the governments won't do it. I mean, even in COVID, you can't. We think, oh, okay, it's the governments developed the vaccines. No, they didn't. The pharmaceutical companies developed the vaccines, and the governments fortunately helped to risk it, so they gave them money up front, and then guaranteed them a market. So it was slightly different, but at the end of the day, it wasn't governments. It was pharmaceutical companies that developed the COVID vaccines, and I think it's the governments gone are the days of the polio vaccine where governments developed it. To be fair, the governments did develop polio vaccines. And I think governments were responsible for some of the early work around the measles, mumps, and rubella vaccine. But at the end of the day, the commercialization phase of vaccines is done by pharmaceutical companies. Yeah.
Thank you. Well, I'm afraid that's all we're going to have time for this evening. Professor Giovannoni, just thank you so much for your time and your wonderful presentation and for answering so many questions. So much there for people to take away. We really, really do appreciate it. And thank you to everybody as well for joining us this evening. We understand that it can be difficult to come on a webinar at 7 o'clock on a Tuesday evening, but we really do appreciate it. And just as a reminder, the session has been recorded and it'll be made available on our YouTube channel and website in the coming days. So if you want to watch back or send it to a friend, for example, you'll be able to do that. So wishing everybody well and hope that you all stay safe in this weather. And Professor Giovannoni, thank you again for your time. Much appreciated. Okay, take care. Bye, everybody.
Take care.